It's really a pleasure just to be back again and to meet all the colleagues. And you ask me about the future of myeloma. And I like to think similarly to a football match. First of all, if you don't know the Achilles heel of the enemy, you will not win the football match. And for this reason, our group in our lab, led by Bruno Paiva, we have decided to concentrate in 4 cell compartments that I think they may be responsible for disease dissemination and resistance. First, the clonal compartment, and we have identified that precursor B cells are already mutated and have gene rearrangement. In other words, our message is that probably there's a pre-malignant situation that predisposed to multiple myeloma early on. Second, we have also concentrated in the microenvironment, not only on the T cells, also in the myeloid compartment, because they influence the outcome of the patients clearly. The third player that we are trying to control is the circulating plasma cell. It's like Messi, the football player, very difficult to control. And they are responsible for disease dissemination. And now we know, we have data, that this circulating plasma cell influence in the speed of progression in a smoldering multiple myeloma, and also has a clear impact, a diagnosis in active multiple myeloma. Probably is one of the most relevant diagnostic factors for prognostication. Last but not least, the resistant cells, because this is the reservoir for potential relapses. And we are investigating what are the genetic difference between the presenting and the resistant cells. With this in mind, the next step for me, for the future, is to have the best tools to identify the efficacy of the treatment. And these are the tools for the identification of residual disease, minimal residual disease, inside and outside the bone marrow. If you don't know the efficacy of the treatment, you are blinded. Third, early detection and early intervention. This is a paradigm in all the diseases. Obviously, it's also, or should be also, in multiple myeloma. And now there is data that in high-risk smoldering myeloma, we can either delay the time to progression or probably trying to have a curative strategy at this timing point. And the other area is the active myeloma. Everybody is expecting, okay, most of the patients present with active myeloma. Standard and high risk. In both situations, again, minimal residual disease is critical, and this should be the goal of the treatment, to try to eradicate the residual cells. This is obvious. And for this, I think will be a wrong philosophical approach not to use the best treatment in a standard risk and to reserve this for the high risk. For the high risk, you need a different approach, more experimental approaches. And here brings the immunotherapy. This will be a major change, and we are facing this change. Now we have data in late lines of therapy with bispecific antibodies, with CAR-Ts, that demonstrate high efficacy, particularly if you think in complete responders that may have already a plateau in 5th line of therapy. Why not to move this early on, particularly starting with the high-risk patients, then probably we will use in the standard risk. Also, you can think not only in the immunotherapy, but we have also other new targets. We have selinexor, we have ebrufen, we have the new generation of IMiDs that could be also very relevant, and also target therapy based on the genetic lesions. Therefore, I think the paradigm has clearly changed, and this is the future.